Welcome everybody, good morning. We're going to have a little presentation discussion on setting expectations as it relates to various clinical settings to try and set an example for some of the things that I think are going to be taught today. I'm going to hopefully set some expectations for this event. So this is intended to last no more than 20 minutes. It'll briefly cover the clinical relevance, obstacles, and a few case studies. And I will at times ask for participation from the audience, but if you have questions or thoughts, please interject at any time. So to kind of get things started off on the right note, we got to just do the housekeeping things. I don't have any relevant financial disclosures. And just a quick little clip from the greatest movie ever. I know the audio is a little bit shallow there. That interaction, he says, "Who are you?" after they've been kind of fighting, and he has all this fancy sword work that he does. He says, I need to know who you are. And he, at the end, says, "Get used to disappointment." And hopefully that's not a reflective exchange of our clinical experiences. So the clinical relevance, I read this great study that mentioned that patients who held an unmet expectation were less satisfied with the care they received, reported less symptom improvement, and reported weaker intentions to adhere to physicians' advice. Pretty significant claim that's there. Why do we think that occurs?
So in our world, in the physical therapy world, we have a thing called, my brain just left me, basically our job is to get our patients to buy in to our plan of care. We have to get them to create this alliance with us. And I think that it's part of it goes right to what you're talking about today about setting expectations. For us, it's important because in physical therapy, if we can't get them to buy in to the plan, they're not really going to get better. We're talking about change that needs to happen. It's not just an injection or an surgery. This is something that has to happen over a period of time, and they need to do the work at home, which is even more important than the work that we do in the clinic. So this goes right to that. This is super important for them to just get buy-in.
Absolutely, appreciate that. How, obviously this is a multidisciplinary group here. How do patients judge or determine the quality of their care? There's different rubrics that you can use. One of them that we may as providers tend to fall back on is, what was the outcome, right? And so, I work in the surgery world. We may say, well, you had a disc herniation, it had led to drop foot, we removed the herniation, and you regained function of your foot, successful surgery. But the reality is, while that may be a yardstick that we can use and should use, it's not the only one, right? Expectations certainly play an important role in that process as well. We noticed in the medical community that post-COVID, there was a significant reduction in the default of patient trust for their providers. Almost at times an antagonistic or pessimistic view when coming in and interacting with the healthcare provider. And so we have to sort of shift away from a paternalistic model to one that has shared decision making, and included in that is kind of shared expectations about what's going to occur. So clarification here real quick. When I was preparing for this, I had always thought of the term expectation of, well, what is it that patients are hoping to have happen? And that's really actually perhaps better described as, what are the patient's desires? But additionally, there are the predictions or the assumptions that patients have about what will happen, and even in their own mind, those may not be the same thing. Why is that? Any thoughts?
One thing is what someone else's experience was like in a similar-ish situation. And that person's memory may have been faulty too, because, over time you forget some of the stuff that maybe was really bad or went really well. And so their expectations are, well, I'm having this and somebody else had this, and so that's how it's going to be for me. And then if it doesn't match that, then they're disappointed.
Absolutely. People come in with anecdotal experiences, both good and bad, regarding treatments and therapy of, hey, my wife did physical therapy after, whatever, and, she didn't really seem to get a lot better. So I have this serious doubt that I'm going to have this improvement. It doesn't mean that they don't want to get better or to have the improvement, but they're coming in from a position of doubt. Thank you. I think it's one of the challenges too of when people come in with desires, it's important to validate them, right? So in that conversation that you're having with the patient, hey, what are you hoping to be the end goal? And when someone has perhaps an underdeveloped desire or set of goals, it's an excellent opportunity, I think, to build trust and to help focus in on what's actually achievable. So I'm sure you've seen this meme floating around, right? We have what a fast food restaurant kind of has on their ads, and then when you go and you pick it up, kind of what you see. Why is there a difference between those two? I mean, we know lots of reasons why, but relevant to this discussion that we're having here. Thoughts? Yes?
I think Western healthcare has set itself up in some ways for failure by using expressions, take 2 of these and call me in the morning. I think the patients who are unfamiliar with the healthcare system come in and expect this magic wand kind of experience. And we all know that there's no such thing as a magic wand. And so when there isn't that one pill, that one treatment, that one thing that's going to magically make everything go back to normal, then we have failed them. And so I looking at this picture, I look at the magic wand versus what's actually out there. And so I think using language within our communication to the patient, and I think a huge part of that is education. I think if a patient understands what it is that we can actually do, what is actually possible to do, then not only do I think they can make good decisions for themselves as to, okay, well, you can't do what I want you to do, what should I expect?
Mm-hmm.
And then I think it opens up a new opportunity for a better conversation so that you actually do have better outcomes for that patient. Absolutely.
Thank you. Appreciate that. Yes.
I also think it's important as providers that we put ourselves in the shoes of our patients. They're bombarded all the time by all these different influences, social media, but also family coming in and saying, well, this is what you should do, and everything like that. And I mean, we have a certain skill set, all of us do as providers, but we also have to understand that, what would we expect in their shoes as well?
Yeah.
And kind of reverse that role just a little bit. Because there's a lot of things we can do, but will work not for every person. And we have to make sure that comes up in that conversation and says these are possibilities, but sometimes the outcome is still unknown. And I think if you can, normalize expectations, and what is a normal thing after surgery, or what is a normal thing after trying these different things that we're trying, then they can be on the same page as you so that everybody's doing the same thing.
Yes, appreciate that. Excellent comments. I think tying into some of what's been said, we are part of a culture that in all things uses advertisements of perhaps what's the best, most idealistic of whatever is happening. So if it's an ad for surgery, there's always the silly thing of everybody in the OR has their masks off and is smiling as someone has a surgical instrument. That's of course not necessarily an accurate reflection of how things occur. medication commercials in particular, everybody's singing and dancing after taking the pill and running through a meadow, and there's butterflies and everything is great. The reality is, treatments are complicated, they have side effects, and they certainly require compliance and buy-in from patients. So this is kind of related to that. I, from time to time, will hear something in an ad, and when my cognitive function is operating at a higher level, I'll notice, well, that's kind of an odd way of doing things. So particularly, one of my favorite advertisement nuances that I'll hear is speeds up to, right? So it'll be speeds up to 100 gigabytes per second. Well, that doesn't mean anything, right? Saying speeds up to is the same thing saying it may work not at all, it may work really well. But you're actually implying that you may get speeds in that range, and the reality is, if you talk to anybody who runs a speed test, it just really doesn't ever match up to what's being promised. So what are some examples as providers where we're committing this same act, right? And sometimes it's intentional and sometimes it's unintentional, where we're essentially saying speeds up to. Any examples that you can think of? Not that you're guilty of it. Let's shift that. People that you've heard say things. Yes.
So I think it's interesting because, again, it comes to this perception. So, we have, I'll just make it a patient. That patient has a foot problem, right? And they're like, oh, my neighbor had physical therapy for their foot and they fixed it and they're back running marathons. So I'm coming to you, fix my foot, I want to run a marathon. And you're like, okay, well, you're missing 4 of your toes. It's not exactly the same thing. And I think that's what happens is they buy into this, like, oh, it can be fixed, so just fix me, like, do it. And so they're coming in with the opposite of that 62%. They have this overinflated expectation of what's about to happen, and then you have to be sometimes it's like, okay, well, let's pause and take a beat. Your injury is not the same as your neighbor's injury, and this is going to take a little bit more work, and that's not necessarily what they want to hear.
Yeah,
sometimes.
yeah. I appreciate that. Any other comments?
That just piggyback on that, I think the language that we use is huge. For example, I was at a family reunion yesterday, and I have a lot of older folks in my, and they all had neuro problems, and so I had this sit down with like 6 of my older folks, and they were like, oh, all the doctors came in and said, I will fix you, and I was like, you got to be careful with that. I said, because this is medicine, and it's not necessarily a fix. It's a help me, but it's not a fix. And they're like, well, that makes sense because I'm in a lot of pain right now. And they said that they'd fix me, and I was like, okay, let's talk. Let's explain through this. But I was like, I'm sure the doctor had great intentions, but the word "I will fix you" has a completely different meaning than "I will help you." And now I have these relatives that that I'm gonna send somewhere else because that's not what their expectation was. Their expectation was, I will fix you, there will be no more.
Yeah.
When really it should have been, I will help you get to the next step. And so that language is super important, and we do it all the time, right? We throw it out all the time sometimes, but it really has to be, again, putting yourself in those shoes and being like, is that reality?
Absolutely. And I think over-promising language, right, overly optimistic language is challenging because obviously we want our patients to have hope and motivation to maximize their outcomes. And so it's hard when you come in and the first thing that you do is chop someone down to size. They may not be ready for that. So it's a delicate balance between kind of inspiring people to buy in, to maximize their effort while you maximize yours to try and see, hey, where will the dust settle? And part of it too is, I know even members of my own family, they have pretty high expectations from healthcare providers, right? You should know how things are gonna turn out. It's not an unreasonable question, but I commonly get questions before surgery from patients where they say, well, how will I be when this is done? the sad reality is I don't have a crystal ball. So the best thing I have is basically statistics based on all the people who have come before. And one of the challenges that's related to this very concept is, even as good as I might think I understand statistics, the reality is probably the patient understands it less. They're not specifically exposed to what the literature says prior to walking into the office. So when we speak to patients, it's important to say, hey, yeah, 98% of the people who have this surgery after 6 months report these symptoms, and then to focus in, but 2% don't, right? And we don't know where you'll be. We're going to try and make sure that this works out as best as possible by doing these things, but these are the potential risks that are associated with it. So when do you start setting expectations? In the beginning, right? If anyone here has some unique things that their practice does about, hey, to get ahead of setting expectations, this is what we do to start on things. Feel free to pipe in. Some of the things that I think are interesting is when we are setting up appointments, what do we tell patients in regards to when to get there, right? Is there a 15-minute period of time we want them to arrive before they meet with the provider in order to fill out paperwork to get their insurance card in? Do we tell them that, hey, you'll actually only be spending 10 minutes with the provider because of some of this other check-in stuff, and then there's going to be this acute time frame? Or do we just let the patients sort of figure that stuff out through the experience? Any practices that you guys have to help establish that expectation with patients? Yes?
I think it's kind of like there's Disney does it really well. Setting the table is one of the ideas behind there, and you've got to create an environment where you're going to be able to listen and they're going to be able to be heard and be able to feel it's safe to speak and kind of like set up what they want and what you want to have happen. That goes everything from what to expect when you get there. Sometimes there's videos prior to, telling them 15 minutes before, there's going to be some paperwork. We start on time, we end on time. There's a lot of factors that go in, and you're going to have to set that up, I guess, for your practice and for what you hope to accomplish as well, even down to how you schedule your appointments and when you come in and when you leave as a provider with your support staff. So
Yeah.
There's a lot of nuance to it on what it is, but at the end of the day, as we're sitting here, you've got to be able to find out what they expect and help communicate. You have to be attuned to that, and those, I think, are the good providers, are the ones that can quickly sit down, assess, create a relationship, and listen and be heard.
Absolutely. Absolutely. Thank you. Yeah.
I think one of the points really is, and you put yourself in your patient's shoes, or put yourself, into your clinic, and then say, what do I want to know about this experience? And the ones that are really good at doing it, and I don't know that we're really good at it, but we try when patients come in, we just want to give them just a quick overview. Like, this is Abby, she's going to check you in and out. You'll come here to do your appointments. We're going to go back to this room, but anything you need to know, the bathroom's in the far corner. The fridge has water bottles in it. Feel free to grab those at any time during your visit. If you want one, just ask, we'll bring it to you. This is how the visit's going to go. We're going to visit, we're going to come, you're going to check out, make your next appointment. This is the gym, this is where we do our work, this is the eval rooms. So, then people don't have to wonder when you have a patient who, think about this, they're like, hey, can I go to the bathroom? Like, yes, you don't need a hall pass, but second, now they have to ask you where the bathroom is.
Yeah.
But if you've already covered that in the beginning when they first come in, even if the receptionist doesn't take you back, by the way, the bathrooms are right here. Like, the patient's like, hey, I'm going to go to the bathroom. Like, that's either somebody's been in your office 150 times, or they know now where the bathroom is. I mean, it's simple. Hey, we'll put your phone and your keys over here, coat rack is here. Just simple things for them to understand how the flow is going to go. Different in our environment because our patients are coming twice a week for, for a little bit more. But that helps people feel at home. in the clinic. I love it when they just go grab a water bottle and then go get on the bike or something. Great. This means that you now know what the expectation is. You understand the flow of the visit, and you're more comfortable. And interesting when it comes to just some of the statistics in the physical therapy world. The top 5 things for patient satisfaction, not one of the top 5 things actually has "I got better" in it when they survey patients. Now we want them to get better, but think about all the other things that are important to them have an experience. That my physician referred to me, was the clinic, was it clean, was my therapist knowledgeable? Like, all those things are much more important than "I actually got better" when it comes to patient satisfaction.
And I would assume part of that is because innately I think people recognize we all die eventually, right? There is a decline that can't be overcome in the ultimate sense, but our journey or our experience, how we were treated, is a recognition of, hey, we were not necessarily there to fix everybody, but we were to help them and maximize their outcomes. Some of the things that I thought of for my own practice is, hey, do we let patients know you should wear comfortable clothing that will facilitate the exam? Do we let them know, hey, if you have allergies, medications, you've had previous imaging, if you can try to write down some of those things, that'll help smooth out the experience in your first visit. Do I tell patients on the first visit, you probably will have to come back for additional visits to discuss all of your concerns? Sometimes when the MA comes in to report, I have to cut them off because we have to go see the patient before they're even getting to the end of that list. And letting people know, hey, it's not that I don't want to hear these things. These are actually things I absolutely want to hear, but it's going to take more time, instead of just saying, nah, I don't think that stuff is important, and cutting them off, right? We need to establish that expectation to help bridge the gap between patients' desires, their predictions, and what we need to have happen. So we're going to launch into a bit of a quick case study here, move along quickly. I'm hoping to get a volunteer. It doesn't have to be a physical therapist, but if a physical therapist wanted to read through this and say, hey, these are, I think, the main things, and give them, what are the key points that you would give in this conversation or this visit with this patient?
I'll say something. I'm not a physical therapist, but some of the orthopedic surgeons I used to work with, I thought it was great feedback because he used to tell every patient that, hey, this is a 50-50 proposition. I'm going to do everything I can to do my 50%, but the other 50% is going to be on you, whether or not this is a successful outcome. And I think it helps set that expectation for that patient to realize that he's not just going to go home and sit in a lounger and he's going to get better. Yeah,
absolutely. So the commitment and compliance with things, yes.
Time frame.
Yeah.
5 days after surgery. I think it's always important, like when I was doing home health, or as I'm still doing it, I would always be like, okay, think where you are this week versus where you were last week, and then think where you're going to be in a week. Like, let's take this on a week-to-week basis, and just know, 5 days out of surgery, you're lucky that you're up and moving sometimes. So let's look at really what the realistic expectations are, and I think it goes into this realistic pain. What are you? I'll ask my patients all the time, what do you think what do you think you're going to be at in pain? And they're like, oh, I'm going to be at a 3, and I'm like, yeah, that's unrealistic.
Yeah.
You should be this and this for approximately this period of time, and we work on that and we keep going. But it's all that realistic expectations. They've probably heard that somebody after 5 days was up and moving, and that's in their mind. That's what they expect. When in all reality, that's not true.
Yeah. I think timeline is absolutely critical. People don't fundamentally know how long things take. It's a tendency for us to just assume, oh man, why isn't this happening? I know I'm an impatient person. I drive into Taco Bell and it's, why is the food not ready? I know it's just been sitting underneath the warmer. If I was wanting something healthy, I'd go somewhere else, right? And so similarly, this patient is not being unreasonable. They are just not informed. You had a comment.
I was going to say, this happens all the time in clinic, and I have to remind patients, you had power tools stuck into your knee, and in this case, a bone saw taking chunks of you off. So It's a big thing. I just had an appendectomy a couple weeks ago, and I went to my follow-up with the surgeon a couple days after, and I said, I feel like the biggest wuss ever. I am so tired. I feel sick. I'm like weak. I have no energy, and this was just a dumb appendectomy. And he reminded me, like, you're fighting infection. You've had pain. You've had a ton of drugs, and I had to have that exact thing that I'm doing with my patients. I had to have it happen to me too, to get my expectations, my understanding of the process back on track. And then I was like, oh, okay, yeah, I get it.
Absolutely. Yeah, go ahead.
The first thing I would probably say after a patient said that to me is that would be something that would be wonderful. That would be, we can certainly hope that at the 2-week mark, you'll be back to normal. The reality is that might not happen. I think because if we completely destroy the fact that the chances of being back to normal is like, oh, you're being ridiculous. No. Do some people do that? Yes. We can acknowledge that sometimes that does happen and give them that hope, because then again, the other 50% comes in and says, well, how can I more likely achieve that goal? Well, you got to put the work in. That's what you can do. We can hope for that, but the reality is it might actually take 3, 4, 5, 6, 7 weeks in order for you to get there. Oh. So I think, again, using language such as, we expect you to get better. No, we can say things like, we hope that what you want is what's going to happen. Let's shoot for that. Let's do everything we can to hope for that. The reality is it might take longer, or it might not be quite there.
Yeah.
That doesn't mean everything's done.
Yep.
It just means we need to make some adjustments to what we're doing.
Yeah, absolutely. I mean, there's a lot to unpack in here. Yes, I'll get you in just a second. This word normal is a little bit ambiguous too, right? How much movement and activity and muscle strength does this 68-year-old have prior to the surgery, right? There is nothing about having a knee replacement that suddenly gives you the muscle mass, balance, and stamina to go back to how you were when you were 20, right? And that is sometimes, I think, something that patients will assume and develop. And we have an excellent opportunity to say, hey, like, we can get you better. That's the whole reason why we're doing this, right? It's not just for changing out a tire. It's to give you increased activity and ability. You were going to say?
That was actually my thought as well. Just setting expectations on what their activity level is going to be before and after. If he's a 68-year-old overweight individual, odds are he's not very active. And then he's expecting to suddenly be able to go travel with his wife and do all these things. He's expecting more out of himself than what he was actually doing before the surgery. I
think we can validate the enthusiasm, we can channel that, we can get buy-in, and then we can help frame it by giving the details of a timeline and milestones. And again, not speaking strictly in terms of population studies, right? Saying, well, most people do this by that time frame. That's fine as long as it's filled up, but everybody's different, and so you're not measuring yourself against other people. You're measuring yourself against the standards that we set up for your specific situation. We're just about out of time, so I wanted to just jump through one last concept, and that is magic fixes, treatment options, and compliance as it relates to these expectations as well. I personally encounter this once or twice a week where someone comes in and I think they genuinely believe that I have a drawer that has the magic potions in it, right? And that there is something that doesn't require medication, doesn't require physical therapy, doesn't require surgery, right? And they're just, that's not real. And those can be challenging, right? Because I think that those are patients who have, it's anxiety, right? It's genuine concern of, hey, I've heard a lot of bad things and I'm afraid. And you have an excellent opportunity, rather than getting frustrated, which is kind of the default for most of us, is say, how can I help you bridge that gap between your concern and where you need to be in order to make the decisions you need to take care of yourself. Treatment options is another one. So I'll actually visually do this with my hands and say, imagine that there's a menu and you're in a restaurant. These are all of the treatment options that are applicable to your particular condition, and go through the pros and cons of each of them. And hopefully at the end of the day, that empowers the patients to recognize, hey, I'm not holding anything back, right? This is what the medical world has to offer. These are the limitations, and I can make recommendations just like a good waiter would perhaps for what I think is applicable to you. But at the end of the day, you have to buy in, which gets to this concept of compliance, right? You have to establish in patients the idea you have to comply, right? The number of patients who you prescribe an antibiotic, and after you meet with them 2 weeks later, they say, I didn't take that, right? Well, you gotta work on the compliance thing, right? And a lot of that comes from setting that expectation as a provider in our visits. That is the conclusion. I wish we had more time. I learned a lot of things from you folks. I hope that in moving forward, we take time to recognize the importance of establishing expectations with our patients, because it's one of the important things for achieving the clinical or the treatment outcomes, as well as meeting the emotional needs of the patients as well. Thank you.